The question I've always wondered, being a pet owner over the course of time, is what we do that's different than what our pets who walk quadruped with 4 limbs, we walk with 2. What is it that is different between us and between them? Well, first we have to understand that there's the big movement rocks. There's 3 regions of the body: the foot and ankle complex, the hips, and the thoracic spine. These are the most mobile regions of the body. I call them the big movement rocks. When they become limited in motion, that's where we typically see injuries occur. Because when we look at the low back, think about it, the low back is stuck between the thoracic spine and the hips, but the hips are greatly impacted upon what goes on at the foot and ankle complex. Secondly is knee. I call the knee the dumbest joint in the body because it's stuck between the hips and the foot and ankle. So we have to understand what's going on above and below the knee to have an understanding of how it's impacting the knee. The third is the shoulder. The shoulder is really dependent upon scapular motion, which is really greatly dependent upon our thoracic spine motion, which is greatly dependent upon our hip mobility, which is greatly dependent upon what goes on in the foot and ankle complex. It's amazing to me when I do a health history of people who have had back pain, of previous injuries that they've suffered in one of the 3, or in many cases, more than one of the 3 of the big movement rocks. These are the most mobile regions of the body. As we age and we become more sedentary, or we have to address our lifestyle, our jobs, our families, and we don't pay as much attention to our physical activity, quite often one of these 3, if not all 3 of these regions, become limited in motion. But we don't see that very much in our pets. So my question is, why don't animals suffer from low back pain? Well, one thing, look at the ankle dorsiflexion on that pup. That pup seems to be going quite efficiently. So let's maybe address a few things and what goes on in gait. First, we have to understand relative position when we talk about biomechanics, the relative bone position of the extremity. So we're going to talk about everything away from the spine. Movement away from the spine is described as the distal bone in relation to the proximal bone. So in this case, I'm going to ask everybody out there, please stand up. Stand up and let's do an open chain, what we commonly call open chain hip adduction, hip adduction. So in this case, take your left leg, swing it across in front of you. You see that it's hip adduction. Let's define this for the moment. The distal bone, that's the femur, in relation to the proximal bone, the ilium. We see that it is adducted. It is medial to the hip. This is open chain. This is what we commonly look at. However, here's what I'd like you to do now. Stand on both feet, stand on a bilateral stance, shift your hips to the left. If you look, you will see that your left femur is medial to your left ilium. That is still considered hip adduction. So we can do it in open chain, but when we look at gait, we see that the hip will move on top, typically will move on top of the femur, and lateral, which still is hip adduction. That's not to say one is right, one is wrong, but in gait, we look at the closed chain, and we'll see that people with back pain often don't get into good hip adduction. Here's a little pearl that we're going to throw out there now, but we'll discuss it a little bit later, is that if you see somebody that is very tight in the frontal plane and have limited hip adduction, that hip will be extremely tight into internal rotation in the transverse plane. Again, you're tight in the frontal plane, you will be limited in transverse plane motion of the hip. Let's talk about the spine now. When we look at movement within the spine, movement is described as the proximal bone segment in relation to the distal bone segment. So in this case, you can do this standing or you can do this seated, but turn your head to the left so that your chin is over your left shoulder. We look at this as commonly as open chain. I suppose we can make a case for that, but think of it more as isolated motion. When people come to you, or even you that may have suffered from a tightness in your cervical spine, in the musculature of the neck, we often turn our head side to side, we rotate it, try to loosen it up. But when we think about it, the great majority of the cervical musculature is attached at the upper thoracic spine. So in this case, we see that your chin, in the picture here, chin is over the left shoulder. But now look straight ahead again. And if you're standing, please continue to stand. Let's put your left foot forward and reach to the right. Turn your shoulders and your chest to the right. Think of it this way. The picture on the left, if you put one hand over the other, point your index fingers. The proximal bone, which is your top hand, turn it one way. We look at the relationship of the proximal bone in relation to the distal bone. So the higher up, the more superior bone segment in relation to the distal. The picture on the left, we could see that the head and the cervical spine is turning to the left. So that would be left cervical rotation. But the picture on the right is more of an integrated motion, and the thoracic spine is turning to the right, which if we reverse this statement at the bottom, if the distal bone is turning to the right, the proximal bone is in relation to the distal bone, the proximal bone is turned to the left. So in this case, we still, in both cases, have left cervical rotation. When people have neck tightness, they come to me and say they've got a kink in their neck. I try and get them to move from the bottom up. Think of the cervical spine in this case as a bobblehead doll. Any movement that you do underneath the head, below the cervical spine, is going to have an impact upon the cervical spine. So as a quick review, movement away from the spine is the distal bone in relation to the proximal bone. But when we talk about the spine itself, we look at the relationship of the proximal bone to the distal bone. Very important, particularly people who have low back pain, because many times when we start their programs, we may pre-position our clients or patients to create the reaction that we want, and we may have them in a staggered stance as an example, because we can conceptually see this is where we want the bone segments to be as they go through various movements. Now, to me, this is the most important slide that I have in all my presentations. This tells us that what happens under normal healthy conditions in the most common joints in all three planes of motion. Keep one thing in mind, is that all muscles, all joints work in three planes of motion. The books don't tell you that. Well, there is one book that does, but the books don't tell you that, generally speaking. But all muscles, all joints work in three planes of motion. What we're looking at here are the most common regions that we see as they go through triplane loading. So to demonstrate this, and being virtual, it's rather challenging at times, but stand up, and we're going to pick on the knee as a quick example. Stand up and put your left leg forward so you're in a staggered stance. Go ahead and just go into a staggered stance. You can call it a lunge, you may call it an asymmetrical squat, but as you go into the lunge and you load, we see that the knee is flexing. And you see that in the sagittal plane, the knee flexes. But take a look at your ankle. Is your ankle dorsiflexing? Let's see how successful that your knee is if you don't ankle dorsiflex. So right now, drift your knee behind your shoelaces. What would be your shoelaces? So your knee should be behind your shoelaces, and your ankle is going to hold more of a 90-degree angle, and try and go through your lunge or asymmetrical squat. You're probably feeling more of a quad load than a glute load. It may feel a little bit uncomfortable, and you may even feel more tension in the quads than you do the glute. Now get your knee over your shoelaces. So you increase your ankle dorsiflexion and do that same motion. You should feel more successful. You should feel more stable. You should feel more glute reaction. and less stress, less loading on the quad. Now what I'd like you to do is find your tibial line. Put your fingers on your shin bone, on the tibia. Start over again, go into that asymmetrical squat or that or that lunge. And is your tibia turning in or turning out? Under normal healthy conditions, the tibia rotates in a little bit. When we look at the tibia in relation to the femur, we see that the tibia is rotating in. If you look under the transverse plane, we see that we have internal rotation. Now get into a bilateral stance, please. So your feet are even about hip width apart. And just imagine that you're a marionette doll and the strings are attached to your extremities, and whoever's controlling your strings lets go and let your body just collapse in. Most cases, your knee is going to squint together. So your knees come together in what we call knee abduction, and that is correct. That's not adduction. This is a tough thing to get the concept of, because people often get this confused. But as the knees come together, look at your tibia. Are they lateral to your femur? In other words, is the distal end of your tibia, as the knees squint together, is the distal end of your tibia lateral or abducted to the distal end of your femur? And the answer is yes. So the knee in this case works in 3 planes of motion for successful loading. It flexes, it abducts in the frontal plane, internally rotates in the transverse plane. That's all dependent upon successful and adequate ankle dorsiflexion. Because what we're going to learn in just a moment is it isn't just ankle dorsiflexion. I got a great question from somebody the other day that was forwarded to me, and please forgive me for not having answered yet, but we're going to address this now as it comes to ankle dorsiflexion. Ankle dorsiflexion is absolutely critical, because what it's going to do is allow us to be able to not only flex at the ankle, but what we'll learn in a few minutes is that the tibia will internally rotate, that calcaneus will evert, and the forefoot will abduct. It will abduct in relation to the rear foot. And we'll explain this a little bit further. But if we don't have those 4 mechanisms working for us, our squat, our lunge, our ability to stand up and sit down from a chair, to go up and down stairs becomes more compromised, and we start to see limitations in gait, and we see compensations elsewhere. This to me is the most important roadmap to understand human movement. It's complex, but at the same time, you already know the answers to this, and we'll be able to explore this a little further later on down the line.